Hello everyone and welcome to this month's BANT webinar. My name is Helen Spriggs and I'm going to be taking you through Ehlers-Danlos Syndrome, zebras not horses. A quick introduction. As mentioned, my name is Helen Spriggs and like many of you, I'm a BANT Registered Nutrition Professional. I predominantly work one-on-one with patients in clinic, but I also do undertake other avenues such as running health classes and health talks both in our clinic for patients but also going out into the community but also local businesses as well. Our clinic is Spriggs Chiropractic Nutrition. We're based in Newbury in West Berkshire and I'm lucky enough to own and run this with my husband Mark, who is our principal chiropractor, and together we provide patients an opportunity usually to get some answers but also providing a personalised care through whichever discipline and sometimes collaborating together. So we both very much work from that sort of functional medicine approach of looking to get to the root cause. So from a physical therapy's point of view, we have on-site x-rays and then we can go on to provide not just traditional chiropractic but also a lot of rehab care. And from a nutrition approach, anything from functional testing through to obviously more of a long-term care rather than just kind of an initial consultation and kind of a one-stop shop. It's that providing that ongoing support where appropriate. My interest in Ehlers-Danlos as a condition was actually sparked during my training at CNM when a colleague who I was training with saw an EDS patient in student clinic who was seeking support for other symptoms, not EDS directly, but as I researched further, it really struck a nerve that as nutrition professionals, we were potentially quite well placed to try and support people with EDS from a kind of ongoing perspective. I've taken that interest further. I work clinically with patients one-on-one, but also earlier this year, the Ehlers-Danlos Society ran Project ECHO for the first time, which I joined, and this brought together a variety of different healthcare professionals in different countries to not only learn more about the condition but also collaborate, discuss cases, understand new approaches that may be suitable for patients with EDS, but I'll touch on that a little bit more towards the end of this webinar. I've taken my interest in both study and EDS further, and I'm currently undertaking my Masters in Advanced Nutrition in Research and Practice with the Northern College of Acupuncture through a distance learning course, even though they're based in York. It's the pathway I'm doing is Middlesex validated, and it's very much being able to take that research element of things. So I'm currently in my dissertation phase and I'm writing a research proposal for a piece of primary research where Ehlers-Danlos patients are my participant group. So there's lots more to come, and so watch this space. A quick rundown on what we're going to cover over the next hour. We're going to talk about what Ehlers-Danlos actually is and the different subtypes, some of the comorbidities and associated symptoms, the process for diagnosis, what the prognosis is and what care is typically available through primary and secondary channels, where nutrition can support and what the evidence surrounding that is, some clinical approaches for you to consider, how collaborative support can be very important, and then some both patient and practitioner resources, and then a quick summary to tie things together. If you have any questions throughout this webinar, my details will be available at the end of it, so please feel free to make any notes or any questions and then send me an email, and I'll be more than happy to either come back to you or arrange a call to answer any questions if I can. So why zebras? You may be wondering why my choice of title was Zebras Not Horses. So this phrase, when you hear the sounds of hooves, think horses, not zebras, is synonymous with medical training, encouraging medical professionals to really not think that every case that they're seeing is a rare zebra, and that often a simple, logical explanation is usually the most correct or the correct option, and to really expect common conditions, not to think that it's a rare condition or a rare complication. However, it's really important to remember that obviously zebras do exist, and from time to time we need to think about, what could this symptom be associated to. Obviously, as nutrition professionals, we are not there to diagnose, we're not primary care physicians. However, we potentially can be there to help connect the dots and make appropriate referrals, because we're using a very holistic approach and not just looking at a single symptom or condition, and that's silo medicine. A quick overview now on what Ehlers-Danlos actually is. So ultimately it's a syndrome, a collection of symptoms, and together Ehlers-Danlos syndromes are known as a group of connective tissue disorders. Sometimes they're referred to as hereditary connective tissue disorders. However, the hereditary component is not fully understood for all types of EDS and therefore can be ring-fenced a little bit. The group of disorders, though, can be characterised by joint hypermobility, skin hyperextensibility and tissue fragility. And this is because of an issue with the quality of the collagen that somebody produces more so than the quantity that they make. Given that collagen is derived from the ancient Greek word kolla, meaning glue, we can start to understand where the issues of collagen can start to find the symptoms coming through in EDS. As mentioned, all connective tissues are involved, and collagen helps to give structure to these, and this can include providing integrity to things like joint stability, integrity to skin, vessels within the body, as well as organ tissue. Therefore, if there's an issue with the collagen, the integrity of all of these connective tissues is affected. That's why it's really important to understand that Ehlers-Danlos, or EDS, is much more than just being bendy. The images on the left-hand side here show certain joints being hyperextended, and that's not through force, it's just the natural extended range of motion. On the right, we can see very stretchy skin, which is another presenting symptom of EDS. As mentioned, collagen is such a key factor within EDS, so just going to give a little bit of an overview around collagen now. Ultimately, it accounts for approximately 30% of proteins found within the body. It's made up of a high proportion of the amino acids glycine, proline and lysine, but also hydroxyproline and arginine is found there. Vitamin C is absolutely required for the use and structure of collagen. It helps interact with the amino acids, it helps stabilise the collagen mRNA to increase production, and it adds hydrogen and oxygen to these amino acids and provides structure amongst the collagen fibres. As mentioned, it's found in a whole host of tissues throughout the body. So for example, within skin, it helps provide elasticity, so both stretch and recoil, and also firmness. Within tendons, which allow muscles to attach to bones, within ligaments that hold two joints together, cartilage, which helps anchors to the bone, and within muscles to provide structure and elasticity, again that stretch and recoil, and within the bones themselves to provide strength, a little bit like scaffolding. Within Ehlers-Danlos, the issue with the collagen, as mentioned, is it's about the quality as opposed to the quantity. And this, in most cases, or at least in some cases, is being identified as because of a genetic factor. And this is where alterations in the genes that code for either the proteins that make the collagen or within the collagen gene itself. So alterations within those genes occur. Either way, this results in abnormal collagen fibres being produced, and this means that they can lack stiffness or strength, therefore leading to potentially a joint not staying in place properly, or resulting in something like a prolapse, for example. The obvious solution or answer, you might think, well, just supplement a collagen, take a collagen supplement, and given there's so many different ones, marine derived collagen, collagen peptides, collagen with vitamin C, which seems a great option to have. You can have hydrolyzed collagen, you can have different formats, so in a powder, a liquid, a tablet, a capsule, but also different types 1, 2, 3 and beyond. However, they're not necessarily helpful for all, given that within EDS there's an issue with that genetic recipe to make collagen. When you take a collagen supplement, it's just a supplement that's rich in the building blocks that needed. So as you take the supplement, it gets broken down into those raw building blocks, which the body has to then rebuild to use. And obviously, if that recipe to rebuild is flawed, we still may not be able to actually produce appropriate quality as well as quantity of collagen. If, however, some people who may report feeling better by taking a collagen supplement within their condition, then it's important to consider, is it they just need to potentially increase those building blocks from a dietary point of view. So potentially a collagen supplement can be helpful to try to see whether or not it may be helpful, and then adjust the diet accordingly. But it also may be that actually it's just a waste of money taking the supplements. It is thought that taking a vitamin C supplement could potentially be helpful though. And this fact put out by the Ehlers-Danlos Society mentions this at the bottom there. Taking extra vitamin C may help as it strengthens the bonds between the collagen fibres themselves. Classification. This is where it can get a little bit confusing for people. So going back, in 1988 there was the first classification for Ehlers-Danlos conditions, and this provided 11 different subtypes that were given the names type 1, type 2 and so on, and this was based on clinical findings and also looking for an inherited factor. It was very subjective, but stuck around for around 10 years until 1998 when the Villefranche criteria came in. And this then took Ehlers-Danlos into 6 subtypes rather than 11 and gave descriptive names such as classical and hypermobile. It was formed of both major and minor criteria that a patient needed to fulfill in order to reach a diagnosis. However, since then, much has changed, and so in 2017, an overall international reclassification of Ehlers-Danlos syndromes was undertaken by a huge cohort of people from around the world specialising in Ehlers-Danlos. As a result, 13 subtypes were identified, and this again still uses a major and minor criteria to reach a diagnosis. But importantly now, genetics have played a huge role in identifying certain types and subtypes of Ehlers-Danlos, as you can see on this slide here. So from the 13 subtypes that are identified, 12 have had the genetic basis and the protein involved identified, which can be seen on the right-hand side here. You may notice that highlighted in red, hypermobile Ehlers-Danlos has not been identified yet. This is something that's being undertaken at the moment. Across all 13 subtypes, there are clinical signs and symptoms that are very similar, but equally there are specific differences, not only the genetics involved, but also the clinical presentations, and some of them can be quite serious. So as mentioned, research is being undertaken to identify the genetic component of hypermobile Ehlers-Danlos through what's called the HEDGE study, where 1,000 patients that are diagnosed under the 2017 criteria with hypermobile Ehlers-Danlos are being used to try and identify the genetic component and the collagen protein involved. This is ongoing, but so far I believe recruitment is going really well. It's not accurately known the prevalence of EDS, however it has been estimated at all types between 1 in 2.5 to 1 in 5,000 people. Hypermobile EDS is considered the most common at somewhere between 1 in 10 to 1 in 15,000, followed by classical, which is between 1 in 20 and 1 in 40,000 people. Certain types are much less common, for example kyphoscoliotic EDS or KEDS. There's been less than 100 cases ever reported. In a recent 2019 study, Demler et al. Looked at a population in Wales of GPs practices and actually found the prevalence of either hypermobility spectrum disorder or hypermobile Ehlers-Danlos to be around 1 in 500, which makes it a lot more common than has previously been found. In terms of male-female prevalence, tends to be more females affected, but again this needs to be looked at, that whether or not there's a genetic component involved, or also there's just been an underdiagnosis or misdiagnosis for other conditions. It's important to remember that there are some other conditions that can present quite similarly to Ehlers-Danlos, and this can include things like Marfan's and also hypermobility spectrum disorder that I just mentioned. Hypermobility spectrum disorder is usually reached as a process of exclusion of other conditions, including hypermobile EDS. There can be different causes for it, such as injury or surgery, which has then led to hypermobility. It may include people who have previously been diagnosed with conditions that were known as joint hypermobility syndrome, benign joint hypermobility syndrome, or in some cases the old criteria for EDS type 3, which is now known as hypermobile. But the classification and the criteria changed, and some people may not fit the new criteria and therefore would be diagnosed with HSD. It's important to know that people with HSD may have other symptoms that includes IBS, POTS and chronic fatigue, and this is something that we'll go on to discuss a little bit more. The process of diagnosis can be long. It usually starts with a GP, a patient presenting to their GP with potentially hypermobility or say dislocation of joints, and then a specialist referral may be made. However, even just to get that process started can be difficult because not all GPs potentially are aware of EDS as a condition and how to go about assessing it. So clinical signs and symptoms, including hypermobility of joints, is a crucial place to start, and the illustration here is used to produce a BANT score, and it looks at hypermobility of specific joints, so the fingers, bending back, thumb to forearm, elbows and knees, whether or not they hyperextend, and also the ability to place the hands flat on the floor without bending the knees. Usually once this process goes a little further, then it may be appropriate to look at genetic testing. And this is illustrated in this visual here, where we have a patient presenting, maybe first of all to a GP with hypermobility, poor wound healing, joint pain and or dislocations, or bruising but with a normal clotting profile. GP may initially assess and then make a referral to a specialist such as rheumatology, haematology, etc. Explore a suspected diagnosis of EDS and make an onwards referral either to a specialist clinic or genetics to rule out certain types of either other conditions or help to confirm a diagnosis of one of the genetic components found in certain types of EDS. The other option may be that a patient actually presents with a much more serious event, such as a vascular event, and likely that would be at the hospital at A&E. Referral may be made to us for surgical consultation, and then again enter into the same chain of suspected diagnosis for EDS, referral to identify the specific subtype. It's important to know that people may go through these circles of referral, presentation and referral several times before they actually reach a diagnosis. And that's usually unfortunately due to a lack of knowledge surrounding the condition and being able to identify some of the different presenting factors involved in the condition. Whilst as nutritional therapists we're not there to make specific diagnoses, it is important to understand what's involved in the process. So from here on in, I'm really going to focus on hypermobile EDS. This is mainly because, as discussed, it's one of the more commonly seen subtypes of EDS, and it's also typically what I see people presenting with in clinic. But because we're not there to diagnose, it's important to make obviously the referral back to either the patient's GP or, if they already have a specialist, potentially open dialogue with them. So just to run through the main three criteria for HEDS diagnosis. First of all, the joints must be assessed. As discussed, that's using the BANT score, looking for hypermobility of specific joints. Sometimes this can be looked at in a historical factor if they don't currently have that, but they do report as a child potentially being able to do the splits very, very easily, or being double jointed, for example. Then the skin must be assessed, and this can include looking for hyperextensibility, so very stretchy skin, unusually soft or velvety skin, abnormal scarring, or even abnormal stretch marks. Involvement of a first degree relative with diagnosed Ehlers-Danlos syndrome, and also assessment of pain. This may be musculoskeletal pain, widespread chronic pain for greater than 3 months, but also dislocations, especially if they're recurrent rather than as a result of trauma. And finally, it's important to exclude any other diagnoses. So this includes other forms of Ehlers-Danlos, which is usually excluded through genetic testing, but also excluding other heritable or acquired connective tissue disorders. This can include autoimmune or rheumatological conditions such as rheumatoid arthritis or lupus even. Another key factor with Ehlers-Danlos, as mentioned earlier, it's not simply about being bendy. There are a number of identified comorbid conditions, and this can include dysautonomia, so autonomic dysfunction, which includes something like POTS. A huge amount of patients present with gastrointestinal issues, and this can be anything from dysmotility, reflux, IBS, gastroparesis, and many, many others. Chronic fatigue. Often patients may have previously been diagnosed with chronic fatigue syndrome, and it's not to say that they don't have it, but it may be in addition to or as a result of EDS. Again, mast cell activation syndrome is another common one that people may have been identified as having, but it could be part of a bigger picture. Other specifics include small fibre neuropathy, cervicocranial instability and or Chiari malformation, and this can often present as headaches, neck pain, and migraines even. Sleep disorders and anxiety are also not uncommon associated conditions. So these conditions and other symptoms can also present, and this is just a few examples. There are so many others that can potentially creep in, and this is where, as nutritional therapists, we can be really well placed to actually start to bring some of these together and ask some questions. So things like flat feet, for example, from a skin point of view, poor wound healing, stretch marks, abnormal scarring, easy bruising. We mentioned headaches and migraines, clumsiness even, increased sweating, TMJ, so temporomandibular joint issues, so clenching of the teeth, jaw pain, tooth damage, teeth in general, poor dental health, not as a result of poor dental hygiene, ineffective anaesthetic or very sensitive to medications, including pain medications, is quite common. Cold extremities, poor nutrient status. If you're testing people and they're just, they report eating well, but actually their nutrient status is very low. Other musculoskeletal issues such as scoliosis, but also things like osteoporosis can be common. And as mentioned, gastrointestinal issues, things like bloating, but also going on to look at things like lightheadedness and brain fog. So lots of these things that we can associate to lots of different symptoms and different conditions, but they do also present here. So I've brought it together under 4 key systems to consider with HEDS, and that involves musculoskeletal system, gastrointestinal, autonomic and immune system. It's not to say that other systems can't or aren't involved, but these are for many people the key factors that need to be considered, made referrals for and worked on. Prognosis is a tricky one. There is no cure, there's no fix, there's no surgery, there's no pill, there's no supplement, there's no food that will fix one, all, or all symptoms or conditions. However, by obtaining a diagnosis, a patient may find that actually they feel reassured and a plan of action can be put in place. Some people perhaps not. They finally get a diagnosis and then they maybe feel that actually, well, there's nothing that can be done for them. However, this is where a collaborative and multidisciplinary approach can be helpful to support them. Care provided is usually symptom and condition management because there is no ultimate cure, and patients really must be assessed on a case-by-case basis due to the individual nature of the condition. Patients may have one, all, some or none of the associated symptoms and conditions, and so to be able to provide appropriate care, appropriate assessment must be done. Self-management is really important. Whilst primary and secondary care do play a role, because this is a condition that patients do have to live and manage, knowing how they can help themselves is really important, and that can mean education at times. Also important to remember that there are specific types of EDS, for example vascular, that can be life-threatening, and this is due to the threat or risk of vascular rupture. So just because you think somebody may be presenting with what appears to be hypermobile EDS, absolutely an appropriate referral must be made to make sure that a patient can be fully assessed properly, to make sure that there isn't a more life-threatening or dangerous version of the condition. Primary care, obviously most patients will encounter some form of primary care throughout or following a diagnosis. And for this can really vary in what it provides, but often will at the very least include medications of some variety. Pain medication is usually common, although as mentioned earlier, patients can often be very sensitive to different medications, and so different ones may need to be tried. Surgery, if appropriate, which may be anything from joint stabilisation to the repair following prolapse, or even dental surgery, for example. And dental care is something that shouldn't be underestimated or overlooked in terms of the requirement. Psychological support is also important, so potentially the referral for something like CBT or talking therapies through their GP. And this can be a number of reasons why patients can benefit from this, feeling that they just need to ask, why me, and try to understand, especially if this is not something that they were aware existed in their family, but also the impacts on social life, working life, school life, depending what stage of life somebody is at. And of course, from primary care referrals through to other specialists or physical therapies can be made. There's some specialist centres around the UK. Some of these are in London. So the Hypermobility Service is based at UCLH. This unfortunately is closed currently for new referrals, and that's from July 2019 through to July 2020. And this is due to such an increased demand for referrals that they just couldn't cope. So they've actually suspended their service for 12 months for new referrals. There's also the London Hypermobility Unit and the Royal National Orthopaedic Hospital. Now that's in Stanmore, and at Stanmore they do provide an inpatient programme that runs for 3 weeks, usually Monday to Friday, and it provides patients the opportunity to engage in effectively lessons on managing their condition. And this can include some dietary advice, information around appropriate exercise, psychological support, and just it's group sessions around problem solving and how to live with their conditions. There's also the EDS National Diagnostic Service, which is in Sheffield. Often this can involve looking at some of the genetics side of things. Secondary care has a really important role to play, as well as tertiary care or just other care available for patients. Once somebody has gone through the diagnostic process and perhaps had first-line care, which may be medications or surgery perhaps, what's the longer term strategy that's been put in place? And this can include things like physical therapies, so that might be your traditional physio, but also other prescribed activities and exercise, finding something that's appropriate for the individual that perhaps can be extended or built upon to continue to build strength, but also make sure that things like osteoporosis don't start to have an effect on people and the loss of bone mineral density through inactivity. Equally, manual therapies may or may not be appropriate for the individual, and again must be assessed on a case-by-case basis. Manual therapies can include things like massage and soft tissue therapy, but also osteopathy and chiropractic. Certain types of EDS are contraindicated to certain types of manual therapies. If a joint is already very hypermobile, what we don't want to do is to be putting force through it that may exacerbate problems. So understanding what type of therapy is appropriate for the individual and the type of practitioner and the knowledge of that practitioner that's developing any type of long-term strategy or providing care to a patient is appropriate. For example, with our clinic, we do provide chiropractic care, but we're not just traditional clicking and cracking that people would associate to chiropractic, but we provide a lot of prescribed exercises and rehabilitation strategies for people. So it's really important just to understand, if you're working as part of a multidisciplinary team for a patient, that everybody's up to speed on what's appropriate for the individual. Going on from that, looking at things like joint protection strategies. Now this may include making amendments to how somebody goes about a certain task, or using things like orthotics, which may be rigid orthotics such as bracing, or soft orthotics, and this can be to joints such as shoulders, knees, etc., as well as traditional orthotics that people think of in their shoes for the feet for fallen arches. Equally, things like taping can be helpful, or in some cases people do need the addition of things like smart crutches or even a wheelchair or scooters. Complementary care obviously can come in all different shapes and sizes, and nutrition often fits within this model, but as well as things like acupuncture, massage we spoke about, talking therapies, other avenues that can be explored that just help provide part of a toolkit for a patient. Importantly, some or all of these may be available through sort of NHS services. Otherwise, people may have private medical insurance that can cover certain aspects. Otherwise, patients may be required to self-fund these, and that can be quite expensive, especially if somebody is not able to work fully through or as a result of their Ehlers-Danlos, which is the case in some situations. This may mean that somebody does need or requires to be assessed for disability benefits and other support available. Occupational therapy provisions may need to be made both in the home and in the workplace, so making sure that patients are aware that these things are available is important. So here we're going to talk about some self-management tools and techniques that patients can utilise themselves to help keep on top of their condition. And it's important to remember a patient may need some or all of these and may need them at different points in their life or to do different things within their life. We talked a little bit earlier about the use of orthotics and joint protection strategies. So here we see a soft shoulder orthotic. These are available for lots of different joints and areas of the body, knees, pelvis, even complete suits if required. And this is something that I'll happily talk to you about more if this is something that is of requirement for your patients. Is something we do in clinic with our patients. Here we see some finger splints. These can be really helpful for people who perhaps need to type a lot or have fine motor jobs, something like a jeweler, for example, where they have a tendency to dislocate their fingers or they're under a lot of pressure. These can just help people manage this symptom a lot easier. Obviously, exercise we've spoken about as being a really important factor for ongoing care and support to minimise other symptoms such as osteopenia and osteoporosis, but selecting appropriate exercise is really important. Here we have an image of someone swimming. Swimming is low impact, that may be helpful, but perhaps not so appropriate for somebody who has skin sensitivities due to the chlorine, and we have to potentially look at other options. So in conjunction with somebody who's aware of a patient's physical condition, suggestions should be made around what's appropriate for the individual. Also knowing when going through exercise and other areas of life, what's appropriate for that person at that moment in time. Being able to know it's okay to take it easy sometimes, using pacing strategies, for example, can be a really important self-management tool. Of course, we're always going to be looking at nutrition as nutrition professionals. However, what's appropriate again for the individual, and when working with them, where are they starting from? So what specific support do they need for a specific condition, and what type of diet are they currently eating? So providing some education around this can allow for the patient to self-manage going forwards, generally speaking. Other areas of support, actually having somebody to talk to, whether that's through formal, say, talking therapies, which may be in person or over the phone, but also just making sure friends, family and colleagues are aware of a situation and times that people are struggling with, or if they're having a particular flare. This is really important to make sure that people have got appropriate support. Also taking a little bit of time out for themselves, get out in nature. People can often become quite insular with chronic conditions, and it's really important just to be able to get out, boost up our vitamin D levels, for example, and just to be able to take some time to reflect, but in positive ways as well. And we talked about complementary therapies, so things like acupuncture, for example, or soft tissue therapies can also be really helpful. Again, these are often things that may not be available to a patient through the NHS, that they have to access themselves and fund privately, but it may be part of somebody's routine that they just know it helps them be able to manage their symptoms better. As nutritional therapists, obviously, we are not there to diagnose, as I've said, and ultimately there's actually little to no evidence that diet alone can resolve EDS. We can't change the genetics of the coding for the collagen. But given that EDS is a multi-system syndrome, nutrition can obviously then look to support people who are presenting with different symptoms or conditions as a result of having EDS. So making sure that you're addressing the areas that are impacted for the person in front of you is the first step to identifying how nutrition can help and where we're best placed to support people. Obviously, as we've spoken about, as nutritional therapists, we're not there to diagnose, but we really can potentially connect the dots for people with a variety of different symptoms, especially if there's been no easy way to explain or identify what's going on for that person. For example, things like headaches and or migraines with no other explanation, lots of gastrointestinal issues, food sensitivities, especially or sensitivities to medications, chemicals, things like poor wound healing, which we'd maybe associate to diabetes typically, but obviously with the collagen involvement here, that can be quite a significant factor for people, or quite noticeable scarring once a wound has healed. As well as looking at obviously the musculoskeletal involvement, people potentially saying they're really prone to sprains, or as a child they used to do lots of party tricks and kind of contorting themselves into lots of different ways. So if you've got somebody presenting to you that's seeking support for any one or number of these symptoms, and you're just thinking maybe there's something a little bit more going on here, making sure you're taking a really thorough case history is obviously really important to be able to just see if there's something that needs looking into further by making a referral. Equally, if you have somebody presenting to you that already knows they have EDS and they've already obtained a firm diagnosis, they might be coming to you for a specific symptom that they're looking for help with and how nutrition. Something like gastrointestinal issues is a really obvious one here, but it can also include things like women experiencing incredibly heavy and painful periods. It may include fatigue, low energy, and even low mood sometimes. Of course, we need to make sure we're looking for both red and yellow flags, and again, maybe being part of a multidisciplinary team. But we are often really well placed just to take that overall holistic approach. We've got the time usually, more so than potentially first sort of contact practitioners such as a GP, to just see if there's something more we need to look at. So it's important to remember that nutrition is not able to fix EDS. It's not something that can be fixed just by eating more of a certain thing. However, it can be used as a tool to try and manage the associated symptoms and/or conditions. There's no clear NICE guidelines or other published guidelines or evidence for Ehlers-Danlos overall in relation to nutrition. However, there is some evidence out there that looks at, for example, gastrointestinal presentations and some of the types of things that can be considered, or for example, looking at POTS and the appropriate salt and fluid intakes of a patient. So we're going to talk about that in a little bit more detail over the next few slides, but it's really crucial to make sure that, as you do with all of your patients, understanding what their goals are so that you can help prioritise the areas that you're looking to support. Talk about what the key symptoms are and therefore the systems that are impacted, and also understand what a patient's relationship with food is. For some people, especially with gastrointestinal issues, diet can often already be quite restricted because of sensitivities that they've experienced and then potentially sort of self-eliminated certain types of foods. And that can leave people with a very limited diet already. And so some of the support may be around appropriate reintroduction or support to allow to get to the stage of reintroduction. Looking at our role as nutritional therapists and what we can offer, I'd really recommend a thorough case history. Sometimes a thorough case history can be more help than any tests, to be perfectly honest, or it allows you to make better selection of tests or make more sense of the information you get from those tests. Obviously, a case history can be partially obtained by advanced questionnaires, and that may be helpful for patients who have got quite a complex medical history because they can consult some of the information they already have before completing the questionnaire to send to you in advance, and then have time to sit down one-on-one to explore certain aspects in more detail. During this, I tend to use the IFM health timeline just to plot, obviously, not just when certain symptoms have appeared, diagnoses have been reached, but also other factors going on, so other life events, and trying to understand, some of the genetics, for example, what family medical history is there. It's a really nice way to capture all of that. Using functional testing can be very helpful. It's not essential in all situations, and it may be that patients already have some test results, for example, blood tests through their GP or specialist. And even looking at some very simple tests such as a vitamin D status might be something as an easy way to start and look at these things. Obviously, there's very thorough and detailed blood panels that can be done where required. Stool tests can be helpful to try and understand things like bacterial balance and look for the presence of, say, zonulin. But also from a SIBO point of view, the breath tests, it's important to understand that the collagen involvement can really start to affect mechanical digestion in the intestinal tract, and that can lead to potential bacterial imbalance, bacterial overgrowths. So making sure that that's something that's at least considered if somebody's presenting with a lot of gastrointestinal issues. Nutrient testing can be a helpful one, especially if there's concerns around potential malabsorption of nutrients. And then that can also help guide maybe over the type of supplementation if that's an avenue to explore. And of course, genetics, and this isn't in terms of looking at what collagen or genetic basis of a certain type of EDS. This is more looking at things like detoxification pathways and how much they are impacted or not through somebody's genetics, or for example somebody's ability, their vitamin D receptors, their ability to actually produce vitamin D themselves. Maybe that allows some areas to explore further. So what's the evidence actually around Ehlers-Danlos and using nutrition? So there's actually very little direct evidence. This paper from 2004 is really a hypothesis paper, and it takes individual symptoms that often present within EDS and looks at the evidence behind using specific nutrients in a supplement form to help support those symptoms. It ultimately effectively brings together a protocol depending on what somebody is presenting with a type of nutritional supplement and a dose. However, it's really important to understand that everybody is an individual, and a single protocol just may not be suitable for everybody, depending on which symptoms or comorbid conditions they have and to what extent they are, an issue for somebody. So whilst it can be helpful to consider papers like this, it's not a kind of gold standard, and it's not really necessarily something that is going to be working for everybody, but certainly a helpful and interesting read, and I'm happy to share this paper with anybody if they're interested in reading it. This is a chapter from a book that was authored by some of the same authors as the previous paper, and this is an excerpt of their treatment supplementation. Now, I'm always hesitant over using that word. Obviously, as nutritional therapists, we are not able to treat anything. But again, this is looking at certain associated conditions and symptoms of EDS and certain nutrition supplements that may be helpful in perhaps managing those conditions, again with a dosage recommendation. Within the same book, it does also cover a prevention protocol, although that is mainly focused around osteoarthritis in relation to EDS. Again, this is not a gold standard. It is not something that has necessarily been proven to work with any number of patients with EDS. It's more of a hypothesis that somebody presenting with, for example, fatigue or bowel issues, these may be helpful, but it's got to be judged on a case-by-case basis. So what evidence is going to be out there in the future? Well, hopefully this study is going to be going ahead. It's a nutrition and EDS study that's been led by Professor Aziz, who is a neurogastroenterologist. He is looking for £250,000 to fund research to look into the effects of changes to the diet on symptoms of hypermobile EDS specifically. He's raised currently around £200,000, so hopefully this will perhaps into next year, 2020, actually be able to get off the ground and look at actually some positive interventions of diet on hopefully the improvement and minimisation of specific symptoms. So clinical considerations from our point of view: what can we do, what should we be considering? It's very difficult to provide an exact this is what you should do, given that every EDS patient is going to be individual because they can have such a variety of different symptoms. But I'm going to touch on some of the main ones that I see quite often, and this is really probably one of the most common, and that's gastrointestinal issues. Certain things that we can look to consider and people report having more success with across other nutrition professionals and other healthcare professionals include using the low FODMAPs, also considering low glycemic load approaches. Considering someone's intestinal absorption capability, it's often quite low, and therefore how can we work on improving that, and what can we do in the meantime to make sure that somebody is getting appropriate nutrition? What's somebody's digestive capability, so perhaps looking to supplement HCl or digestive enzymes. Getting somebody to review what their eating habits are to make sure they can maximise absorption, so perhaps slowing down their eating more mindfully. Also the use of things like prokinetics, depending on what somebody's bowels are actually doing, if they need to be encouraged to move more due to the impairment of the mechanical side of things. Of course, gut flora is important, not just in maintaining good gastrointestinal health, but also obviously looking at the gut-brain connection and the ability to actually metabolize and synthesize other nutrients. And of course, food sensitivities is an important one here, and that can be as a result of the intestinal health overall, but also the types of food that somebody is consuming. So some of the things we can start to consider is the use potentially of pre or probiotics, especially if a patient is or has been on antibiotics. Antioxidant rich and colourful and varied foods, and whole food, which is usually rich in fibre, and limiting processed foods. These are not groundbreaking, they're not anything you probably don't already know, but it's important to make sure that your patients do, because Often, as I mentioned earlier, they can be on quite a limited diet because they've chosen themselves to exclude certain foods with little guidance around perhaps what a balanced diet is or what a healthy diet is. It's more about what they feel better on or they feel less bad on. So certain things to look to avoid or limit can include limiting fructose intake to around less than 25 grams a day, limiting gluten and casein sources, and avoiding alcohol. Often people don't react very well with alcohol due to impaired detoxification pathways. Avoiding lots of refined carbs won't be anything of a surprise, and also anything fake, and this can be sweeteners, lots of food additives and stabilizers. Again, often people can be quite sensitive to these factors. Other systems that may be involved can include the immune system, so things like mast cell activation syndrome are certainly not uncommon, and using a low histamine approach may be applicable here. Looking at things like POTS, which is postural orthostatic tachycardia syndrome. This is something that affects blood flow and circulation and can be obvious if somebody's really struggling with going from either a seated or a laying position to standing, like headedness, dizziness, even passing out, especially if it is then alleviated by sitting or laying back down. Things like the electrolyte balance needs to be considered here. Salt is something that a lot of people have become very aware of in terms of minimising their salt intake, but actually with POTS it may be actually a specific increase needs to be made of their salt levels and considerations around their fluid levels. B12 is also something that should be considered in POTS, as deficiencies can be an aggravating factor to the condition. Nervous system. This can be obviously wide-reaching in terms of somebody's ability to have good quality sleep. Stress can be in there, so using potential supplements or herbs even around that, but also lifestyle management skills and techniques, which may be needing some influence from an external support. Of course, gut health is vital for making sure that there's appropriate neurotransmitter balance there, so back to that gut-brain connection and supporting the gastrointestinal system as well. Hormone regulation can be a significant factor for some people within EDS, so really making sure that that's being addressed properly, and that may be in fact through detoxification support to make sure that detoxification and elimination pathways are working as optimally as they can for the individual. And of course, again, things like hydration levels have to come into effect here, as well as micronutrient support. Musculoskeletal system can't be ignored, as it is often such a big factor for people, so making sure there's appropriate protein intake, for example, but equally the use of other disciplines and other people within somebody's support team to address this area. Certain nutrients that are reasonably common, or certainly not uncommon, that I see either deficient or certainly insufficient, can include vitamin B6, B12 as discussed, especially with POTS patients, vitamin C just due through its crucial role in collagen. Vitamin D, again, this isn't necessarily exclusive to EDS patients, but certainly people who are spending potentially more time inside, if they're not so active, it can be even bigger factor. And magnesium as well. Again, this can be an involvement in many of the symptoms that present, including with those with increased heart rate. It can actually help reduce that increased heart rate. And it's really important, if you are using specific sort of targeted supplements, to think about the type or the format and the method of delivery. So what's appropriate? Is it a capsule? Is it a tablet? Do we need to be looking at powders mixed into fluids? Is it something that's already a liquid? Can sublinguals work if intestinal absorption is potentially compromised, or potentially a patch? Now, a patch may not work if somebody has a lot of skin sensitivities. So really just taking time to think about not just what your favourite is, but what's the most appropriate for the person in front of you. Of course, cellular health cannot be ignored, and making sure just some very obvious but simple steps to check the adequate protein and enough and varied protein to make sure we're getting all of the essential amino acids into the body. Appropriate good quality fats shouldn't be underestimated in the importance of cellular health. Making sure, obviously, micronutrients, as we just touched on, are being included in the diet, and of course ultimately we're trying to get all of these through the diet, but potentially supplementation may be required at least for a short-term period of time, and minimizing toxins to make sure that the cells themselves, but also other areas of the body like the liver, are not under unnecessary stress. So if somebody is smoking, if somebody works in an environment that is highly polluted or has to work with chemicals, they're working in a hair salon or they're working in a factory, what steps can be taken to really minimize the toxins or support the body in being able to eliminate them as effectively as possible. I've mentioned all the way through this presentation about working from a collaborative approach with people, and I'm lucky enough to work in a collaborative environment, but I still have to engage with people outside of our clinic, and it's crucial with working with people, not just with Ehlers-Danlos, but actually with any type of chronic condition, to make sure that you're clear of your role within that collaborative team, and just to make sure that the best is being done to advocate for that patient, because often that in itself, a patient is left not really knowing the best way to turn. Obviously, we can't influence and tell a patient what to do, but just knowing that they've got somebody in their corner can be really helpful, I've found. So think about working on, obviously, case-by-case basis. Think about who else is involved in somebody's collaborative team, who's managing and leading the case. Often this might be a role for the GP, but not always the case. It may be a specialist, such as a rheumatologist. Obviously, with your patient's consent, open a dialogue with the case lead and the other people who are potentially involved in somebody's care, such as a psychologist, a physical therapist, as well as a specialist. Try and get to understand if they're knowledgeable about EDS, especially if it's something, for example, like psychological support or physical therapy, just so that you can all be on the same page and talk a common language. Try to understand what their role, but also what yours is within a team, and what the role of the patient is, how active and proactive are they being in their care. And be really clear on your own scope of practice. Obviously, we have our professional guidelines and we can't overstep those. So making sure that you're engaging with other people within the team is a great way to make sure a patient still receives all-round care. I've just put together here a few examples of some great resources, both for practitioners but also for patients. I pretty much own all of these books and I've read them all, and I find them quite helpful. So there's just some examples here, and I'll happily send people details of these, or if you've got any questions around them, feel free to contact me. Here are a few resources that you can use online. So the top two here are a couple of charities and organisations that I actually think are helpful, but for both patients but also practitioners. There's some great learning tools on there to be able to understand more about the conditions, but also videos, webinars and other links to information from conferences that have been held. The GP Toolkit was mainly designed for hypermobile EDS, and it's actually designed by the Royal College of GPs and EDS UK to provide a selection of pieces of information, resources for GPs, but actually I think it's helpful for all healthcare professionals that may be working with EDS patients. So as nutritional therapists, perhaps something to just take a look at and provide to patients if they're then seeking support through their own GP. I also did put together a Facebook group. It's called Practitioner Support and Resources for EDS. The link's here, and if anybody is interested, you can just search for that on Facebook and I'll accept you into the group. It's where I put up any research that I come across or information surrounding any other resources for EDS. I mentioned right at the start of this presentation about Project Echo that I joined earlier this year. The next one of these is running in January. It's 9 sessions running between January and April, and this time they're going to be running on Tuesdays at 12 p.m. I assume this will be the same as last time. Each session was an hour and a half in length, and most of the sessions were based around a specific area or comorbidity or group of symptoms involved in EDS. So for example, gastrointestinal involvement or urogynecology involvement. There was also weeks where there were opportunities to present your own cases, as well as discussions across all the different people involved, which included rheumatologists, GPs, gastroenterologists, paramedics, people like myself as nutritional therapists, and based not just here in the UK, but also America and New Zealand. So if you're interested in joining this, it's free to join. You do also get CPD hours for it as well, and it was just a really great opportunity to join together if this group of people is something that you're working with or coming to work with a lot. In summary, just to bring together today's presentation, my 3 key points really are making sure that you're taking every patient as a case-by-case assessment. Obviously, that's an approach that we tend to work with as nutritional therapists anyway, but whether somebody is presenting to you that already has EDS, they may not be the same as a previous EDS patient you've seen. Equally, if you're seeing somebody who has not got a diagnosis of EDS, but you're suspecting it due to its multi-system condition and a variety of symptoms that are appearing that aren't responding to other care, then allowing you to connect the dots and make the appropriate referrals to make sure that it's a collaborative approach. And that does include the patient. So if somebody's already got an EDS diagnosis and they're seeking support from you, try to understand who else that person is working with and how you can help be a part of that team alongside them. I'm borrowing the premise of the canary in the coal mines from Dr. Heidi Collins, who I saw do a presentation a couple of years ago around EDS, and she spoke about how canaries are kind of Ehlers-Danlos patients. They're kind of hypersensitive to their surroundings and therefore can act as a bit of a warning sign for everybody else. So a canary down the coal mine, maybe it's the Ehlers-Danlos in society today. So thank you very much for your time. Thanks for listening. A whole host of references here that today's presentation is being based on. And if you do have any questions off the back of today, feel free to email me. I can be contacted here on my direct email, or you can find me through social channels at the handle @Spriggs Nutrition. Thank you very much.